This is Selma Schimmel for the group room at the San Antonio Breast Cancer Symposium. We are joined now by Dr. Kent Osborne, Professor of Medicine, Director of the Dan L. Duncan Cancer Center, and the Lester and Sue Smith Breast Cancer Center at Baylor College of Medicine in Houston. Hello, Dr. Osborne.
Good afternoon.
I believe you are the co-director?
Yes, there are three of us now. Myself, Peter Abden, and Carlos Arteaga are the three co-directors for the meeting.
And while I called it the annual San Antonio Breast Cancer Symposium, and actually this is the 35th year.
Correct.
Let's talk about some of the meeting highlights that you feel are the most important that distinguish this year's meeting. And is there a theme to this year's meeting? Do you have a tagline this year?
It would be a little bit hard to put a theme together, although today's session, which was largely devoted to HER2 positive types of breast cancer, and there were so many good talks in the session today that that could be a theme, I suppose. But there were a lot of good research discoveries that were presented in a variety of different forms and types of breast cancer so far. The ATLAS trial, for instance, that tested whether giving tamoxifen in certain patients for longer than 5 years might be better, and it looks like it is. And so this gives the doctor an additional treatment to use in certain patients, not all patients, not everybody who's completed 5 years of tamoxifen needs to go on to 10 years of tamoxifen. If they have a very low risk, good prognosis tumor, you're not going to gain much. But for other patients, it's going to be a very important thing. Patients will like it because they don't like to come off these drugs at 5 years. Invariably, many patients say, instead of saying, oh gosh, I'm sure glad I'm finished, they say, oh, now what happens? And where's my insurance policy?
You feel like a sitting duck.
Exactly. Even though you explain to them that there's this carryover effect and that the treatment effects last for a very long time. Now, many of them will be gratified to hear that they don't have to stop it, they can continue it. In the HER2 area, I think there were also a number of, some of them confirmatory, but also new things. And I think one of the interesting papers was the HERA trial, which everybody's been waiting for a long time, for many years. The HERA trial randomized patients, this starts now many years ago, to either just chemotherapy, which was the standard at the time, or chemotherapy plus 1 year of trastuzumab, known to the patients probably as Herceptin, or 2 years of Herceptin or trastuzumab. And people wondered whether 2 years was going to be better. On the other hand, it's a very expensive drug, and what if it is better? That's really going to upset economic apple cart, so to speak. So anyway, the results are now available, and 1 year is just as good as 2 years. Or putting it another way, 2 years is no better. And so 1 year is going to remain the standard. At the same time, there was a French trial that looked at 6 months versus 1 year. And overall, 1 year was better than 6 months. But there were a few subgroups there that it looked like 6 months might be adequate. So I think there'll be a lot of work in the future looking to see, are there certain subgroups of patients who don't need a full year at all? They can be treated with lesser duration of this drug, which of course would be a good thing if we can identify the patients who fit that category. There were also studies are now starting to come out. There were several publications just a few months ago in Nature about finding mutations in HER2. Now, HER2 we've known for a long time, ever since Dennis Slayman and Bill McGuire published a paper in 1987 using our tumor bank in San Antonio for the samples, that about 20% of patients with breast cancer have too much HER2. It's overexpressed in their tumor. And then Dennis went on and developed trastuzumab or Herceptin to inhibit HER2, and that's made a major impact. And HER2 then was gene amplified, which is a form of a mutation. There's just too many copies of the gene, and that was how it did it. Well, now we're finding that there are mutations in HER2. HER2 is not overly expressed or amplified in these patients, so it would be negative. If you did an routine assay for HER2, they would test negative. But about 2% of patients, not very many, but it's important for them, have a mutation in HER2 that activates it. So now the HER2 is behaving almost as if there was too much of it. But instead, there's not too much of it, but what's there is super active and is activating the tumor. So we can identify those patients, and they would require a different kind of therapy targeting the HER2 than just Herceptin. And this is just the first of, I'm sure, many, many papers that are going to come out in the next few years looking at gene sequencing and genetic alterations of one form or another that will help us personalize medicine. So patient Smith will get X and patient Jones will get Y based on the genetic profile of their tumor. We already do it a little bit because we select patients for HER2, or we select patients because they have ER in their tumor, estrogen receptor. But it's even going to be more finely tuned than that. And that data is exciting, and it's going to be, this is the first of it you've seen now, and there'll be more coming out.
What are the practice-changing events of this meeting? I'm going to guess that the Atlas study may certainly be one of them, but as the meeting comes to a close, what do you think are the major studies that are just going to translate into the community?
Well, I think there's several that will. We heard the more conclusive results of a trial that looked at a higher dose of fulvestrant, otherwise known as Faslodex, that we've been waiting for. A number of us many years ago thought that the dose was too low, and finally studies were done looking at a higher dose. And so the higher dose is clearly the way to go now. That's one. The Atlas trial with longer tamoxifen is another. There's also some results that are negative, but we'll still have practice changing in the sense that we don't have to worry about giving 2 years of Herceptin after chemotherapy. I'm trying to think of another one in that area. We had the long-term results and biomarker studies of some of the large HER2-positive trials that suggested that tumors that have a PI3 kinase mutation, that's a gene that's involved in a growth factor pathway, that they may need to have, in addition to drugs that block HER2, like Herceptin, they may need to have a drug that blocks the PI3 kinase pathway. Now, that's not ready for the community yet. Trials are underway right now to test that, but I wouldn't be a bit surprised if the next meeting or the meeting after that will have the data necessary to translate that into the community. So I think there are a number of things that come out at each of these meetings. It's like putting together a puzzle. Each little bit of data, whether it's positive or negative, helps to fill in the puzzle, and we're gradually building that puzzle, and be nice when we get to the last piece.
Dr. Kent Osborne, co-chair of this annual San Antonio Breast Cancer Symposium, professor of medicine, director of the Dan L. Duncan Cancer Center, the Lester and Sue Smith Breast Center at the Baylor College of Medicine in Houston, Texas.
Thank you, you too.